Serotonin is a neurotransmitter. It's one of the most important neurotransmitters in the treatment of depression. Serotonin is made from tryptophan, which is an amino acid. Where does tryptophan come from? Tryptophan comes from food, such as meat, eggs, pork, poultry, salmon, caviar, nuts, pumpkin seeds, lentils. The body uses tryptophan and it converts it. It's sort of a bi-ring. It has two rings called an indole ring. And what the body does, it hydroxylates it, puts an OH on it, decarboxylates it. That's the second enzymatic reaction. It takes off a carbon and two oxygens. In order for that to happen, you need magnesium, zinc, pyridoxine, which is B6, vitamin C. So that's good to know. In order to make tryptophan, you need food, and you need those four cofactors or vitamins in order for this enzymatic reaction to take place. Where is serotonin made in the body? 95% is made in the gut. 5% is made in your brain, in the raphe nuclei. If you were to take your spinal cord and go up straight into the base of your brain, the brainstem, that's where the raphe nuclei are, and they make serotonin. The intestines, stomach are also a site of production of where serotonin is made. The receptors, which we'll talk about, there are 7 classes, 14 subtypes. There are 17 classes. They all use proteins to send their message, except for 5-HT3, which is sort of a tunnel, an ion channel. Where are the serotonin receptors? Well, they're in the central nervous system, which we all assume because it treats depression. But it's more than that. It's in the smooth muscle of the gut. It can make the gut work faster, help you digest, contract the stomach, involved with a lot of digestive processes. It's in the lung, the heart, the adrenals. It's in smooth muscle of all of the intestinal and stomach and all of the vessels of our body. So it can dilate or constrict vessels. It's involved in thermal regulation. It affects growth hormone, prolactin, cortisol, and guess what? Serotonin breaks down to melatonin, which makes you sleep. That's all very interesting because now we're seeing a very complex array of areas and functions of serotonin. It's not just it treats depression. So we're talking about depression. We all know about Prozac, fluoxetine, Zoloft, sertraline, Trintellix, vortioxetine, these SSRIs, Luvox, fluvoxamine. I'm doing brand name because I don't know what people know. I'm not getting paid off by any drug company. I take zero money. So we all know that there's a serotonin transporter pump. Here we have my little diagram. Whoops. So now let's go like that. This is the synaptic cleft right here. This is the serotonin transporter pump. This is the cell body. All the drugs, selective serotonin reuptake inhibitors, block the pump and keep serotonin in this thing called the synaptic cleft. Why is that important? Because on this cell body are receptor sites for serotonin. And there's also autoreceptors here. 5-HT1A autoreceptors. 5-HT1A postsynaptic receptors. It is one of the most important receptors in the treatment of depression. The theory of depression is if we increase serotonin in this intersynaptic cleft right here, that treats depression. But that's not how it works. When the body senses there's too much serotonin here, there's also these 5-HT1 autoreceptors here, and to a lesser extent, postsynaptically here. And they tell the body, hey, there's too much serotonin. And they're responsible for shutting off the production and release of serotonin. This takes 6 weeks. It's genetically modulated, meaning the cell, the nucleus of the cell, gets a certain amount of DNA material stimulated to tell the brain, stop making so many of these autoreceptors because there's too much serotonin and we want to turn off the production and release of serotonin, both presynaptically in the 5-HT1 autoreceptors and postsynaptically. And when they do the SPECT scans and the PET scans, they find that depression is caused by too many 5-HT1A autoreceptors, because what's going on is the brain is saying, don't produce serotonin and don't release it. That makes a lot of sense, doesn't it? So the way antidepressants work are by increasing the intersynaptic clefts levels of serotonin and thus causing a downregulation or decrease in 5-HT1A autoreceptors that tell the body, stop making serotonin and stop releasing it. So we change the structure of the brain when we add those selective serotonin reuptake inhibitors. I wanted to clear that up because all my patients come in, they're always like, oh, you need more serotonin. You don't. You need to change the body's 5-HT1 autoreceptors that tell the body to stop making serotonin and to cut off production. Now, I talked about the 5-HT1A receptor. It is the most abundant receptor for serotonin in the brain. Not in the body, but in the brain, because we know that 95% of serotonin, which acts locally in the gut, in the intestines, and then to a lesser extent, lung, heart, adrenals, and it also has effects on prolactin, and serotonin gets converted to melatonin, which makes you sleep. Growth hormone makes things grow, it heals things. Prolactin is involved in the immune system, it's involved in our sexual functioning, it's involved in milk production, and now let's talk about the 5-HT1A receptor. If you stimulate that receptor, that's the happy receptor. Let's remember it like this: 5-HT1A, anti for A, anxiety for A. It is anti-anxiety and anti-depression. So if you stimulate that, what you're doing, it not only works in treating depression and anxiety, but also it decreases the pain response. So morphine, tramadol also stimulate the 5-HT1A receptor and help decrease pain, increase learning, increase mood, decrease anxiety. It also is involved in thermal regulation of the body's temperature. Now, which drugs affect the 5-HT1A? You want to know the most powerful one? It's what my patients abuse: MDMA, ecstasy. Ecstasy is one of the most powerful 5-HT1A agonists or stimulatory drugs out there. It makes sense because when people take it, they feel happy, more friendly, decrease in aggression. Because what you're doing is, through a downstream effect, by stimulating the 5-HT1A receptor, you are increasing dopamine in the frontal lobe. Makes you feel good, makes you feel happy, makes you feel loving, outgoing, decreasing aggression. Okay. What other drugs do that? Buspirone. It's a weak 5-HT1A. It has some anti-anxiety effects. It doesn't work that well. But here's a key point. There's some antipsychotics out there: aripiprazole, ziprasidone, clozapine, and olanzapine. Those four stimulate the 5-HT1A receptor. can make you happy or less depressed. So along with using antidepressants like fluoxetine, sertraline, paroxetine, fluoxetine, vortioxetine, you can add on to those drugs, which are blocking the serotonin presynaptic pump and increasing intersynaptic serotonin levels, but you can then potentiate their action by using an atypical antipsychotic or buspirone that stimulate the 5-HT1A receptor. Now, it may be in the future that we come to the point where we can use ecstasy to treat depression. And I think it's very promising. I can't prescribe it, but I have patients use it. And I think with appropriate dosing and appropriate spacing of that dosing, you can treat depression. There are two antidepressants, vortioxetine and vilazodone, to a lesser extent trazodone, that stimulate or are agonists at the 5-HT1A receptor, improving depression. An antagonist of this is ergotamine. And that would be used in the treatment of migraines. Now, what happens at the 5-HT1B receptor? There are 7 families of serotonin receptors. There are 14 subtypes. The 5-HT1B is the calm down vasoconstricting receptor. Now, what do I mean? That receptor, if you stimulate it, the 5-HT1B, you decrease dopamine, you decrease serotonin, you decrease glutamate. Remember, glutamate's activating? So you calm people down. You take away their dopamine, you take away their serotonin, you calm them down. Now, dextromethorphan does that. Chlorpheniramine does that. Geodon to a lesser extent. Here's the big one. All the triptans. All the drugs used for migraines, which I've used them all because I have migraines, and they're miserable drugs to use, I think. But they stimulate the 5-HT1B receptor, which is vasoconstricting, and vasoconstriction helps decrease migraines, right? But also, when you stimulate the 5-HT1B receptor, you know what you do? You increase obsessions and compulsions. So when you're treating migraines with triptans, sumatriptan, zolatriptan, naratriptan, relatriptan, frovatriptan, you know all those names, Imitrex, Frova, Relpax, they all stimulate or agonize the 5-HT1B receptor. When you agonize that one, you'll be real careful because you make obsessions worse. So does chlorpheniramine, an antihistamine, and so does dextromethorphan. Dextromethorphan, just to let you know, also has anti-opiate effects, and that's why I use it for cough. But listen, you're giving a drug to make obsessions and compulsions worse. You got to be real careful what you're doing. Now get this. If you antagonize the 5-HT1B receptor, you know what you do? You increase glutamate, you increase dopamine, you make people agitated, you do something else. Abilify and yohimbine both are antagonists at this receptor. And you know what they do? It increases cravings. Now, I've had people take Abilify, aripiprazole, and it is antagonizing the 5-HT1B receptor. Oy! You know what it does? Makes them crave sex, gambling, shopping. They become very, very impulsive to do these things. I've had people gamble, get in dangerous sex, shop. It's a weird side effect of Abilify, but when you mess with that receptor, it makes people crave like crazy. Now we move on. The 5-HT2A receptor. Okay. This is another receptor where people abuse it. You know what that receptor hits? That receptor causes increased dopamine release in the prefrontal cortex. You know what that does? Makes you hallucinate. Can make you super creative. You know what does that? Psilocybin, mescaline, lysergic acid. It makes you hallucinate. But if we block that receptor, like olanzapine blocks it, all the atypicals, Geodon, Abilify, they block the 5-HT2A receptor. Mirtazapine does, trazodone does. But when you block the 5-HT2A receptor, you stop hallucinations. You stimulate it with LSD, mescaline, psilocybin. You make people hallucinate. Now, I'm not sitting here saying when you stimulate that 5-HT2 receptor, it's such a bad thing. Because what also I read was it can also increase the scaffolding and of the brain, the microglia, and release factors like BDNFN, brain-derived neurotropic factor, which make the brain grow and enhance its ability to function. So maybe lysergic acid or mescaline or psilocybin will have therapeutic benefit since it's being studied right now in the treatment of depression. But to antagonize the 5-HT2A receptors, that's kind of what I know, like olanzapine, clozapine, aripiprazole, ziprasidone, they block that and they treat psychosis. Trazodone and mirtazapine also block the 5-HT2A receptor. Now, here's a problem. There's something else that also stimulates appetite if you block it. So mirtazapine, olanzapine make you eat. If you antagonize the 5-HT2A and 5-HT2 receptor, you increase people to eat. If you stimulate those receptors, you decrease people's appetite. Loccaserin is the only one I know that is an agonist at 5-HT2A and 2C. So stimulate 5-HT2A, you get psychotic, acid, psilocybin. Antagonize or block it, you get antidepressant effects and antipsychotic effects. Abilify, ziprasidone, olanzapine, clozapine. Now, what does the 5-HT2B receptor do? If you block that receptor, you treat migraines, it has a lot of cardiac effects. Now, once you get past, now let me go to the 5-HT2 receptor agonism, which increases dopamine, may increase craving for alcohol. If you stimulate it, it decreases appetite. If you antagonize it, it has antipsychotic effects. And I already talked a little bit about that. The 5-HT3 receptor, which is one of my favorite receptors. And why do I say that? If you stimulate that receptor, you block nausea. No, I think if you stimulate the 5-HT2 receptor, you get nauseous. If you block it, 5-HT3 antagonism, like Zofran, ondansetron, and mirtazapine, an antidepressant, you block nausea. So I'm always taking these drugs, triptans, remember them? The ones that are 5-HT1B, and they cause nausea. They are agonists. And so if you can block the 5-HT2/3 receptor, you treat nausea. So I'm always taking ondansetron, Zofran, or mirtazapine to block the nausea. You stimulate that receptor, you get nausea because it hits the central trigger zone in your brain. It's called a chemotactic trigger zone. Stimulate it, you throw up, you get nauseous. Block it with ondansetron and mirtazapine, it stops nausea. So mirtazapine, Remeron, blocks nausea. Zofran, which blocks this 5-HT3 receptor, is responsible for treating nausea. We see where the receptor is, where the serotonin receptor is where it works. It's a locally acting, I think it's called autocoid, meaning where it is where it works. If it's in the gut, it affects the gut. If it's in the brain, it affects the brain. 5-HT4 is in the GI. It causes GI motility. It's in the brain, the urinary tract, the adrenals. It also affects memory and learning. The 5-HT4 agonist that I know of is metoclopramide, which treats gastroesophageal reflux disease. It treats nausea, vomiting, and it treats gastroparesis, where your stomach's not working. If you stimulate it, the 5-HT4 receptors, your stomach works better. Listen, once we got past 4, that's the basic knowledge of serotonin receptors. Now we're getting into 5. 5-HTA is involved in memory. But here's one thing. Valerian root affects that receptor, and that receptor, when affected by valerian root, causes depression. There's the 5-HT6 receptor, and this one, when you stimulate it, slows you down. Slows down dopamine, slows down norepinephrine, and increases GABA. Well, that combination appears to make you learn better. So now they're looking at that receptor for Alzheimer's disease, so you can learn better. If you antagonize the 5-HT6 receptor, you increase glutamate, increase dopamine, and increase norepinephrine. You stimulate people so much, they don't like it. The 5-HT7 receptor, you stimulate it, makes people depressed. You antagonize it, people become less depressed. This is the gist of serotonin. In encapsulation, or in conclusion, my favorite comment, it affects all aspects of the body. Like I said, it's not just the central nervous system. It's not just in depression. Look, it affects migraines. It helps you stop nausea. It helps you treat gastroparesis. It helps with learning, thermal regulation. It affects prolactin, cortisol. It affects melatonin. It affects growth hormone. So it affects smooth muscles in your gut, meaning makes the gut move, slow down, constipation, diarrhea. It causes nausea or treats nausea. It is involved in so many different aspects. And I manipulate these different aspects of the serotonin receptors to treat people. For example, the 5-HT1A, remember? You stimulate that, you decrease pain. So when I'm treating pain, I try and use 5-HT1A receptors. And remember, with the 5-HT1A, antipsychotics like Abilify, Geodon, clozapine, olanzapine treat depression, help treat depression. So this is the gist of what I wanted to talk about with serotonin. I hope this was helpful. Listen, there's no way for me to make this simple. I did the best I could to keep it simple for people. This is at the medical student, resident, nurse practitioner, physician assistant level. It's not really for the layman, but maybe someone could watch it and get some benefit. More about this on my blog. Thank you, Dr. Mark Agresti.